Venetia, Dr. Venetia Grace Fonseca. She's here, yeah, she's here. She's all ready. So she's going to present her paper on a case series showing clinico-etiological profile and management of peripheral ulcerative keratitis. Kindly stick to your time.
A very good afternoon, respected judges. I'm Dr. Venetia Fonseca, a second-year postgraduate from Sarojini Devi Eye Hospital. Under the guidance of Dr. Vijay Lakshmi ma'am, my paper is a case series showing the clinico-etiological profile and management of peripheral ulcerative keratitis. So it's an inflammatory condition starting off as a subepithelial infiltrate with an overlying epithelial defect and progressive corneal thinning. It can have systemic or local causes. Murren's ulcer is a diagnosis of exclusion without associated scleritis or collagen vascular diseases. It occurs in the peripheral cornea. Here, eventually collagenases and MMPs lead to progressive stromal lysis. My aim is to study the demographic profile, clinical features, etiology, management, and outcome in patients with PUK. Methods. It's a prospective interventional case series conducted over a period of 6 months with a 6-month follow-up. A total of 22 eyes of 12 patients were included. A thorough clinical history and examination was done. We included all cases having a crescent-shaped ulcer within 2 mm of the limbus and excluded any PUK-like lesions like neurotrophic ulcer and marginal keratitis. Methodology. We recorded the visual acuity on Snellen's chart. A complete slit lamp examination was done. Fluorescein staining to see the extent of the epithelial defect. IUP, as we're going to start steroids in these patients, and Schirmer's test. A panel of investigations like ESR, CRP, RA factor, ANA, ANCA, Manto, chest X-ray, and corneal scraping should be done to come to the etiology. Coming to management, these cases are managed medically or surgically based on severity. Steroids are the mainstay of treatment as they reduce inflammation. Topical steroids are initially started early and eventually taper off after ruling out infection or perforation. Oral steroids are added in severe cases. Adjuvants like cycloplegics, anti-glaucoma drugs, TS supplements, and antimicrobials should also be used. In cases not responding to steroids, we're going to put them on immunomodulatory drugs. Surgical indications, like especially done in impending perforations to maintain tectonic stability, failure of medical therapy, and for visual rehabilitation. Coming to my surgical options, we could do a conjunctival resection, 2 clock hours on either side of the ulcer. For perforations less than 2 mm, cyanoacrylate glue and BCL could be done. For larger perforations, a patch graft with 10-0 nylon sutures was done, and penetrating keratoplasty is another option. Coming to my results, out of 22 eyes in 12 patients, most were male patients with a mean age of 70 years. Most were coming from rural areas, and a bilateral eye involvement was more commonly seen. The vision at presentation, around 7 patients had counting fingers of 1 meter at presentation, and they came with other symptoms like pain, photophobia, watering. Most of them presented 1 month after the start of symptoms. The inferonasal quadrant was most commonly involved, as increased incidence of tear pooling occurs in this area. Based on the stromal involvement, we divided it into mild, moderate, and severe cases. Associated ocular symptoms like signs like meibomitis, corneal edema, corneal thinning, and dysmetocele. Eventually, perforation with plugging of iris, and scleritis were seen. We investigated these patients to see the cause. Out of this, 5 patients were negative for all investigations. Hence, we say that Murren's ulcer was the most common etiology. Rheumatoid factor was positive in 3 people, and ANA in 2 patients. Corneal scraping was negative in all the cases. Coming to treatment, the primary goals of management were to decrease inflammation, promote epithelial healing, to prevent perforation, infection, and lastly, to restore vision. Topical steroids were used in 15 cases, and in 5 cases, which were thinned out after applying a glue BCL. In 3 patients prior to keratoplasty, prior to patch graft, we added IV methylprednisolone. Methotrexate was added by the rheumatologist in those patients having a systemic disease. Coming to surgical intervention, cyanoacrylate glue BCL was put in 5 eyes. Resection along with TABCL was done in 7 eyes and patch graft in 3 eyes. This was a video demonstrating the conjunctival resection. This helps in around 4 mm is excise of the conjunctiva. It reduces the blood vessel supply, which brings the inflammatory mediators and the collagenases. And you can see in the thinned out area, cyanoacrylate was applied. This is the pre-op and post-op pictures. 3 cases had recurrence. The limitations were a small sample size and inadequate duration of follow-up. A similar study was done by Sharma et al. In North India, but they had a larger sample size and unilateral presentation was more common. In conclusion, a thorough ocular and systemic investigations are necessary to detect the etiology and to manage. A delayed presentation was associated with more severe disease, necessitating awareness. PUK may be the initial presentation of potentially life-threatening systemic diseases. Each case should be tailored. Mild cases can be treated medically, but surgical procedures would be required to preserve globe integrity. Close follow-up is needed to prevent recurrence, infection, and rejection. And you have to partner with a rheumatologist, as some cases can have severe morbidity. These are my references. Thank you.
Excellent presentation. For moderate cases, like you have shown, patient with the peripheral ulceration, mid-stromal ulceration,
Yes, sir.
and all investigation negative.
Okay, sir.
Murun's ulcer.
Yes, sir.
So what was your treatment in these cases? You have shown some glue application, and
Yes, sir.
so what was it? Was a
So if
short?
there was thinning, if there was thinning, we put cyanoacrylate glue and contact lens, bandage contact lens. We continued our antimicrobials or steroids.
See, there are two theories of treating like Murun's ulcer or PUK. One is the shotgun therapy, then is the stepwise treatment. So for these patients where there was no perforation, did you consider conjunctival peritectomy with BCL alone,
So
or conjunctival peritectomy with cyanoacrylate with BCL?
initially, if there was no perforation, initially we started on medical management. If there was no response to medical, then we considered a resection and continued medical treatment. Still, if it was needed, then we added oral steroids.
Any patients who were not responding to the routine medications, as you decided to hike up the routine immunosuppressive medications also?
Some patients which were not responding, first we started with topical steroids, eventually oral steroids had to be added. And the patients who came with systemic diseases, the rheumatologist himself started immunomodulators like methotrexate weekly treatment. So they were also saw to it. And prior to keratoplasty, like patch graft patients, those patients we gave IV methylprednisolone.
How did your series differ from the others reported in the literature? What was your objective basically?
So basically, I wanted to do an overall study to see, to come to the etiology, more like a demographic profile, and how the outcome. Like I have not seen such a study done in South India, so we wanted to do that, and we had quite a good amount of patient load, so we decided to.
So did you find anything extra, anything different specifically from the North Indian profile or compared to the other places?
There was a bilateral involvement
in all
most commonly
most of
seen.
your cases.
Yes.
And what was the possible reason for the bilateral involvement, simultaneous bilateral involvement in your case?
We got like systemic.
You would be having some theory about it.
Like a systemic, like fiber positive for systemic causes as well.
Okay.